All right, let's jump right into this explainer. Today, we're totally bypassing the basic physiologic reviews because we need to immediately isolate the exact structural and kinetic markers of pediatric airway collapse and acute obstruction. We are targeting high-stakes, high-yield clinical variants, focusing strictly on the intricate mechanisms and discrete management steps you absolutely must master to navigate these critical, split-second emergencies.
Starting off with the absolute most common cause of infant chronic stridor, laryngomalacia. Basically, increased laxity of the supraglottic structures drives a dynamic collapse during inspiration. You're dealing with tissue that simply lacks the rigidity to remain open under negative intrathoracic pressure. The result? An unmistakable inspiratory squeak or stridor.
Now, since this dynamic collapse is completely gravity-dependent, there's a very strict positional parameter you have to look for. The stridor absolutely worsens when the infant is supine, meaning they are lying flat on their back, and it definitively resolves, or at least significantly improves, when they are placed in a prone position.
Let's switch gears to vascular entrapment. Vascular rings are formed by an abnormal development of the aortic arch that physically encircles both the trachea and the esophagus. Because this is a fixed external mechanical compression, it uniquely generates a biphasic stridor, meaning you're going to hear it on both inspiration and expiration. And keep in mind, it strictly does not improve with positioning or routine medications like bronchodilators.
When we put these two head-to-head in a clinical variance box, notice how vascular rings strictly pair a fixed biphasic stridor with solid food dysphagia. This makes total sense because of that dual entrapment of both the airway and the esophagus. That is completely unlike the isolated, purely inspiratory, positional stridor of laryngomalacia, which lacks any true dysphagia.
Let's test this with an integrated assessment. Imagine you have a 4-month-old infant presenting with noisy breathing since birth that specifically worsens when crying or lying flat. You perform a flexible laryngoscopy, and it reveals a classic omega-shaped epiglottis prolapsing over the larynx during inspiration.
Faced with this exact scenario, you have 5 distinct interventions to choose from. You need to evaluate the clinical stability and the anatomic findings to isolate the absolute mandate. Is it 1, reassurance and observation, 2, oral corticosteroids, 3, racemic epinephrine, 4, surgical correction, or 5, endotracheal intubation?
Here is the crucial takeaway. Moderate laryngomalacia spontaneously resolves by 18 months of age as the cartilage naturally stiffens, making reassurance and observation the only correct choice here. Let's quickly dissect the traps. Oral corticosteroids and racemic epinephrine treat inflammatory edema, not structural laxity, so they're totally useless here. Surgery is strictly reserved for severe cases with failure to thrive or apnea. And intubation? That isn't just wrong, it is a massive overreaction for a stable infant with chronic laryngomalacia.
Moving on from structural anomalies, let's tackle acute airway emergencies and intervention thresholds, starting with croup, or laryngotracheobronchitis. Unlike the structural laxity we just talked about, croup is an acute infectious process driven primarily by the parainfluenza virus. It causes severe inflammatory edema that strictly narrows the subglottic airway.
Radiography brilliantly captures the classic steeple sign. This sharp, tapered appearance of the trachea visually confirms the subglottic narrowing, which directly generates that hallmark, barky, seal-like cough and inspiratory stridor. Moderate to severe cases present with resting stridor, absolutely mandating immediate medical intervention with corticosteroids and nebulized racemic epinephrine to shrink that inflamed mucosa fast.
On the flip side, acute epiglottitis is a catastrophic supraglottic threat. Historically driven by Haemophilus influenzae type B, making it highly suspect in unimmunized kids, this pathogen triggers a rapid, abrupt swelling of the epiglottis. The presentation is unforgettable. Severe respiratory distress, high fever, intense drooling, extreme dysphagia, and a highly toxic appearance.
Because the swelling is so extreme, the child's airway is literally hanging by a thread. Direct visualization, trying to grab a throat swab, or even just general agitation in the ER can trigger a sudden fatal laryngospasm and complete airway closure. Your absolute mandate here is bypassing everything else for immediate transfer to the operating room. An expert must perform an emergent endotracheal intubation in a perfectly controlled setting.
Putting croup and epiglottitis side by side highlights exactly what you need to isolate. You're contrasting the slow viral prodrome, low-grade fever, and barky cough of subglottic croup against the acute, toxic, high fever, drooling, and tripod positioning of supraglottic epiglottitis. Croup responds to medical therapy, but epiglottitis, that is a strict surgical airway mandate. Let's run through a classic high-stakes scenario. An unimmunized 3-year-old is rushed into your ED. The child is sitting, leaning forward with their neck hyperextended, which is that classic tripod position. They've got a high fever, they are continuously drooling, and they have severe inspiratory stridor.
Review these 5 distinct choices. Which intervention rapidly secures the airway without triggering a lethal spasm? 1. A lateral neck X-ray. 2. Racemic epinephrine. 3. Emergent OR transfer. 4. A direct throat examination. Or 5. An albuterol nebulizer.
This clinical picture strictly dictates option 3, emergent OR transfer. Let's exhaustively break down these lethal traps. Attempting a direct throat exam is an absolute contraindication. It can instantly kill the patient via laryngospasm. Sending a highly unstable kid for a lateral neck X-ray just delays life-saving airway control. And racemic epinephrine or albuterol, they are completely ineffective against massive bacterial swelling. You have to secure the airway first, period.
Now let's transition to a localized kinetic event, acute unilateral obstruction from foreign body aspiration. This usually happens in young kids playing with small objects. Because of the sharper anatomical angle of the left main bronchus, aspirated objects almost always bypass the left side and lodge directly in the more vertical right main stem bronchus.
Chest films brilliantly illustrate the immediate consequence of this anatomy. You essentially get a ball valve effect. Air easily gets in during inspiration as the bronchus expands, but it's trapped and cannot get out during expiration. This creates localized right-sided hyperinflation, visually confirmed by the increased radiolucency on the right side, and a mechanical mediastinal shift pushing the heart toward the contralateral left side. It's vital that you decisively separate foreign body aspiration from an acute asthma exacerbation. Aspiration hits with a sudden, acute onset of unilateral wheezing and focal decreased breath sounds in an otherwise perfectly healthy kid. Asthma, on the other hand, gives you bilateral wheezing, widespread hyperinflation, and almost always comes with a chronic reactive history. You simply cannot afford to misdiagnose an aspiration as a standard asthma flare.
Let's lock all this in with our final third-order clinical vignette. A previously healthy 4-year-old boy is brought in after a sudden episode of severe coughing while playing. The physical exam reveals right-sided unilateral wheezes, and a chest radiograph demonstrates distinct unilateral right-sided hyperinflation.
Among these 5 specific conditions, you need to select the precise pathology matching this sudden onset kinetic event. Is it 1. Asthma, 2. Congenital lobar emphysema, 3. Foreign body aspiration, 4. Laryngotracheitis, or 5. Pneumonia?
The exact pathology here is option 3, foreign body aspiration, which absolutely mandates a rigid bronchoscopy for removal. Notice how asthma is totally ruled out by the strictly unilateral clinical and radiographic findings. Congenital lobar emphysema is a genetic malformation that causes distress by 6 months of age, never suddenly at 4 years old. Laryngotracheitis presents with a viral prodrome and upper airway stridor, not lower unilateral wheezing. And finally, pneumonia requires infectious signs like a fever and focal consolidation, not radiolucent hyperinflation.
Wrapping up, successfully managing pediatric airways means you have to perfectly map the structural mechanisms, whether it's supraglottic laxity, subglottic infection, or a unilateral mechanical obstruction. Always respect the strict positional parameters and anatomical boundaries of airway pathology. And I'll leave you with this final provocative thought. When the stridor suddenly stops in a severely distressed child, they haven't gotten better. They've tired out. Are you already prepared to definitively secure the airway?